Hi everyone, Lucia Gambuza here with Ophthalmology Times. Joining me is Dr. David Folden of Twin Cities Eye Consultants in Minnesota, whose research on capsulotomy size and effective lens position earned Best Paper of Session at ASCRS earlier this year. It's work with real implications for IOL calculations and refractive planning, and we wanted to give it a closer look. Dr. Folden, thanks for being here today.
Yeah, thanks for having me.
Let's get into it. What makes effective lens position such a persistent challenge in achieving refractive predictability after cataract surgery?
Well, I mean, it's something that you can't directly measure before surgery. You're measuring axial length, Ks, anterior chamber depth, and other biometric data and plugging them into formulas that is predicting where the optical plane of that IOL is likely to reside. Um, but I think it's more than just measuring that biometric data. It's also influenced by what's happening at the time of the surgery and after surgery and the healing of that capsule tissue around that lens implant. And so I do think that it's about the postoperative configuration of that capsular bag. And I think it depends on also, to a certain extent, the capsule contractile forces and the way the capsule remodels around the implant. And so I think that those forces can cause the IOL to settle slightly anterior or posterior to the position that was predicted by the formula. And so, currently formulas don't account for the surgically created anatomy, specifically, and in this case, anterior capsulotomy is my area of interest. It doesn't factor that in. And so that's what my research explores. It's exploring whether that may be one of the remaining variables contributing to uncertainty in effective lens position and refractive outcomes and refractive error.
So, is that what prompted the question of whether capsulotomy diameter itself might play a role, or was there something else?
Well, I've performed femtosecond laser cataract surgery for many years. It's a high percentage of my volume, and I'm accustomed to treating capsulotomy diameter as a parameter that I can adjust on the fly, and I do that all the time, and I do it for various reasons. I do it based on the patient's pupil dilation. I do it based on the density of the cataract, the size and shape of the cataract, the lens thickness, to help facilitate safe removal of the cataract. So I'm accustomed to doing that all the time. And over time, I began to question, whether me changing that capsulotomy diameter was potentially impacting where that lens was ultimately settling. And and the diameter perhaps was altering the forces acting on the IOL and how the capsular bag contracts and remodels around that lens implant and potentially impacts effective lens position. So I was starting to question that. And I thought then that if you could confirm on that relationship and perhaps quantify it, and I thought quantifying it might be possible, especially if you can use the precision of the laser and get exactly the diameter you're looking for or what you're trying to compare it against every single time, that if you can quantify it, then you could potentially use it as a modifiable refractive variable that could then be incorporated into IOL power selection or potentially used to finesse the anticipated refractive outcome around a selected IOL power. So yeah, I applied for an IIT. I took a deeper dive in the literature. Actually found a couple of papers that looked at this, quite a few years ago, that did suggest that there was a relationship between effective lens position and what was a manual capsulorhexis at the time. And so, as I mentioned, the studies used a manual capsulorhexis. It was, I would say, highly variable in that regard. And I thought there were some other study design limitations that likely masked the true effect and maybe limited the utility of what they were finding. And so I wanted to conduct a study that had better control of the biometric and operative variables. And paramount in that was to use a laser to construct that capsulotomy so we know exactly the diameter every single time. And so the goal was to study whether two precisely created capsulotomy diameters could produce a measurable difference in effective lens position. And I would also mention too, it was very important that the two diameters still maintain surgical standard of care, and that both remain within the boundary of the IOL optic, so that you still have 360 degrees of anterior capsule overlap.
Okay, thank you so much for walking me into that thinking. And this leads really well into my next question before we get into the findings of the study. How was the study designed to isolate the effect of capsulotomy size from everything else that varies between patients?
Yeah, so the important point here is that it was a contralateral paired eye design, and that 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 doesn't guarantee the two cohorts are identical in every single way, but it gets it as close as possible. We did look to make sure that there was no statistically significant difference in terms of axial length and lens thickness and antechamber depth and the others. Um, and so there was no statistically significant difference between the two cohorts in that regard. It was a prospective design. It was randomized and paired eye. We looked at 40 different eyes, or 40 eyes from 20 different patients. We use the same intraocular lens, a single piece acrylic from Johnson & Johnson as a ZCB00. It's got a planar optic haptic orientation, and it's got a 6 mm optic. Um, in one of the eyes, we used a 4.6 mm capsulotomy. In the fellow eye, we used a 5.6 mm capsulotomy. So again, both within the confines of the optic, both had still 360 degrees of anterior capsule overlap. We looked at 3-month postoperative anterior chamber depth. Uh, um, that measurement, we looked at anterior chamber depth measurement, which is serving as a proxy for effective lens position. And we measured with swept source OCT imaging. We looked at it both in the undilated and the dilated state. They're pretty much consistent. We did subtract out the patient's preoperative anterior chamber depth to just try to provide a good clean number for each eye of every patient. And then we just looked at the average of the two cohort of each cohort, the 4.6 versus the 5.6. But getting back to the question, it was number one, it was a paired eye design, and number two, it's laser created capsulotomies that allowed us to tightly control the variables.
And let's shift over to the findings now. What happened when the two capsulotomy sizes were compared at 3 months?
So overall, we found a very modest difference between the two, about 59 microns difference between the 4.6 and the 5.6 millimeter cohorts. With the eyes that received the larger capsulotomy, those intraocular lenses were positioned posterior compared with the smaller capsulotomy by 59 microns. So, while the overall results suggested a very modest effect, we wanted to understand if this was consistent across different preoperative biometric characteristics. And so we found a fairly significant difference in terms of magnitude and directional trend related to patients' preoperative lens thickness. And so we then stratified based on preoperative lens thickness. And this is where, more interesting observations emerged. We found that eyes that were thinner, 5 mm or less, in that cohort, eyes receiving the larger capsulotomy were positioned about 119 microns posterior compared with the smaller capsulotomy. And so that's much more meaningful and would expect to have or to create a little bit more of a hyperopic outcome relative to what the goal was. On the other hand, lenses that were thicker, 5 mm or greater, in that cohort, eyes receiving the larger capsulotomy were positioned about 123 microns anterior compared with the smaller capsulotomies. And that's fairly substantial, and that would be expected to create a myopic outcome relative to goal. So it suggests that based on that magnitude, it suggests the capsulotomy diameter appears to be a factor in determining or having a more meaningful impact on effective lens position, and that lens thickness can impact the direction of that change. So, so there's a lot of numbers and a lot of anterior, posterior. I just to kind of like summarize, a patient that's undergoing cataract surgery has a lens that is 5 millimeters or less, as a surgeon is shifting from 4.6 to 5.6 millimeter capsulotomy, it'll have a posterior positioning effect of about 120 microns or a hyperopic offset. Patient undergoing cataract surgery that has a thicker lens, 5 millimeters or greater, as the surgeon is shifting from 4.6 to 5.6, should have an anterior positioning effect of about 120 microns or a myopic offset. And I don't think it's trivial, because when you consider an average power lens, intraocular lens placed inside the eye, a 20 diopter lens, if you can predictably manipulate the position of that lens 120 microns, you can have a refractive effect on the patient of between zero point 0.1 to 0.15 diopters or more. And, and that increases substantially with higher power lenses. And that's important to realize as well. And so I do want to emphasize these were directional trends. I think it showed proof of principle, didn't reach statistical significance. So we do need a larger, more powerful study to verify and expand on these early trends.
Of course, and I appreciate the breakdown. I'm sure our audience will appreciate that as
Yeah.
well. And I don't want to stump you here, but why do you think lens thickness will change the direction of that effect?
So I'm not 100% sure on the exact answer. I try to reason through this, and so I think of it in terms of the capsule contractile forces around that IOL, and and how that plays with the overall geometry, not necessarily lens thickness, but maybe the overall geometry of the capsular bag. And so in terms of the forces, it's a culmination of the forces produced from the anterior capsule and the peripheral capsule and the posterior capsule. And they're acting in many different directions on the IOL capsule complex. Um, with some net directional effect that either keeps it stable, planar with what we're expecting, or manipulates it a bit anterior or posterior compared with expectations. And you would think that the net effect should be impacted by the amount of anterior capsule tissue that remains. And it may be this resulting net force from either larger or lesser amounts of anterior capsule tissue and how it plays in the setting of the overall capsular volume, the overall geometry, the general shape of the capsular bag that may have that resulting effect that we're seeing. You know, Lens thickness is that one parameter that we can measure pretty easily with biometry and with the femtosecond laser during the actual procedure. But perhaps that's just identifying the biomechanical context in which a particular response is more likely. But in reality, it's maybe a little bit more complex than that and involves uh, uh, more geometry than that.
For a surgeon planning a case today, what does this suggest about how capsulotomy size should be approached?
Well, I think most importantly, our findings suggest that capsulotomy diameter variability, even when it is within the surgical standard of care and you have 360 degrees of optic overlap, the capsulotomy diameter variability is not refractively neutral. That's what I would take home from this study. Um, at this point, based on that, I would emphasize consistency. Rather than intentionally attempting to manipulate the refractive outcome and adjust the capsulotomy diameter based on the early findings of this study, I would emphasize consistency and use a repeatable anterior capsule diameter for your cases, reanalyze postoperative outcomes, and then optimize their surgeon-specific IOL formula constants. That would be a great first step. Um, a femtosecond laser is very helpful in this regard because it allows for perfect sizing every single time. And at least with the LensR laser, which is what I use, it allows for perfect placement on the geometric center of the lens, and that's important too when you're manipulating the size of the capsulotomy. and going larger, especially to ensure that it's in the center. But anyways, the laser is I think is helpful in that regard, and that's kind of where I'd start. But in the near future, I would hope a validated nomogram would allow us to move from consistency to then deliberate patient-specific customization and manipulation of the diameter to attempt tighter refractive outcomes.
As expectations around premium and presbyopia correction lenses keep raising, where is the biggest remaining gap in refractive accuracy?
Well, I would argue that it's not only in our inability to completely eliminate refractive surprises and just general refractive error, but also our limited ability to finesse that final refractive outcome, our inability to deliberately manipulate surgical variables, and I think maybe that's what grabbed my attention and where I thought the gap was originally, and why I took an interest in this and did some research on it. And perhaps those two frustrations are related. So, as an example, modern formulas provide very accurate predictions, but the available IOL powers that are recommended don't always place the patient exactly at the desired refractive target. So if a patient is undergoing cataract surgery and has a goal of plano, and the surgeon's trying to achieve that, a formula might provide two options, a 20 diopter lens, but that might predict a slight hyperopic postoperative result. Or the next power up, 20.5 diopter, might predict a slight myopic postoperative result, but close to plano. So today, the surgeon is generally selecting the IOL power that represents the best compromise. So it would be valuable to have a surgical variable or something that could provide a predictable refractive adjustment around that selected IOL power. So going back to that example, perhaps a surgeon would choose that 20 diopter lens, which is predicting a slight hyperopic outcome, but it could be paired with a capsulotomy diameter that produces a small anterior positioning or a myopic offset, moving the result closer to plano. Or the surgeon could choose a 20.5 diopter lens, which is predicting a slight myopic outcome, but it could be paired with a capsulotomy diameter that produces a small posterior positioning or hyperopic offset, moving that result closer to plano. So the goal is to prevent surprises and any refractive error if that's possible, and or just refractively, as I like to say, refractively finesse the predicted result around a chosen IOL power and sort of hedge the results towards that exact refractive goal.